Now we are moving to the next speaker, Professor Dario Palladini. He's Associate Professor of Obstetrics and Gynecology, Head of Fetal Medicine and Surgery Unit, Genova, Italy. He will address us about fetal cardiac ventricular disproportions.
Hello, can you hear me? I hope so. Thank you for inviting me to this nice meeting. I would like to thank Russia and the organizers and the chairs. My talk will be on ventricular disproportion, as you see here. What is the different issues that should be considered? Okay. Hope the video will play nicely on your screen. The first question we have to address is what is indeed ventricular disproportion, because we have visually and subjectively various degrees of disproportion. You may have mild disproportion, you may have moderate disproportion, or you may have obvious disproportion, as in this case, or even you have extremely severe disproportion, which, by the way, should not be mistaken for an apoplastic left heart, because the apex of the heart is still made by the ventricle on the left side. So this is not by any means an apoplastic left heart, is extremely severe ventricular disproportion. So there are, here you see 4 degrees of ventricular disproportion, and we have to find our way in describing what is indeed moderate ventricular disproportion. So if you look in the literature, you see that you find that normal diameters or areas between the right and left ventricles is roughly 1.3 in favor of the right side of the heart. So I would say the clear disproportion may be set at 2, twice as large for the right side heart versus the left side, or moderate disproportion is anything in between 1.4 and 1.9 if you compare the right ventricle to the left ventricle. So this should be considered moderate to moderately severe ventricular disproportion. This is not by any means a scientific concept, which has not been supported by any paper so far, but going by rationale, this may be considered as a moderate ventricular disproportion. However, the first point that I would like to draw your attention to is that we do not recommend to measure anything in the fetal heart just by looking at the 4-chamber view and get a subjective impression and see whether it's an obvious finding or if you have a doubt that might be a moderate ventricular disproportion. Because if you measure anything on the fetal heart, you have to be quite experienced, because due to the cardiac cycle and the movements and the changing planes that you may get, you may create artifacts. So only the expert should measure structure at the level of the fetal heart. So if the impression of disproportion persists after you get an apical and then a transverse 4-chamber view, and then refer the case for echocardiography. Now, the checklist that you have to keep in your mind if you want to carry out an examination of the fetal heart in case of ventricular disproportion is made by 4 points that you should be able to demonstrate. First of all, you should demonstrate the venous returns to the left atrium, because you should rule out the total form or abdominal pulmonary venous return. So at least 2, if not 4 pulmonary veins should be seen, 1 per side, to be entering the posterior wall of the left atrium. Then this next question you should ask yourself if there is any hint of a dilatation of the coronary sinus, which is a structure which is here on the top of the mitral valve, and which in normal condition you do not see if not using very high resolution equipment. And then I will come to this, expand on any of these points in the following part of my talk. The third issue that you should consider is that if there is any direct sign of the aortic coarctation, so rather move from the 4-chamber view to the 3-vessel view to check this item. I tried to open my camera, but it was blocked by, it says I cannot start the video because the host has stopped it. And then the fourth point that I have, I hope it works, is if there is a redundant foramen ovale flap. Okay, so these are the 4 points to assess. The first one is whether you have 2 pulmonary veins draining in the left atrium to exclude the complete format of abnormal pulmonary veins return. This is a second trimester view, and you see these 2 tiny tags and the posterior wall of the left atrium. They do represent the entrance of the pulmonary veins. And it's, of course, easier if you move on the third trimester heart, because these become more prominent. Okay. You may use three-dimensional ultrasound to check for the pulmonary veins. But with recent innovation in technological advancement in 2D Doppler, with the recent modes that are quite sensitive, you see that you can get this kind of glossy aspect, and the Doppler is much more penetrating. So I would just recommend to use these new tools, both with the color Doppler and the reduced PRF, or with power Doppler in order to see the pulmonary veins. And with the same sensitive tool, it's also very easy, just turning slightly your transducer to display the 4 pulmonary veins entering the posterior wall of the left atrium. Doesn't take so much of an experience to get this view. You just have to tilt slightly your transducer, and you get the 4 pulmonary veins return. What we should try to rule out is this image here, in which you have the pulmonary veins which do connect on the posterior wall of the left atrium, but they do not enter at all the duct chamber. You see there is a bridge of tissue in between, and this is a complete form of total abnormal pulmonary veins return. And this is what we should try to exclude by carrying out our examination. Then the next point is if there is any evidence of coronary sinus dilatation at the level of the left atrium. And this is a normal for chamber view. And this is a moderate dilatation of the coronary sinus, which is this tiny structure that you see here. And this is a moderate dilatation of the coronary sinus, still, this round structure on the top of the mitral valve. And this is severe dilatation of the coronary sinus, and you see here. Now, what is behind this dilatation of the coronary sinus? The coronary sinus is a structure which develops early in gestation, around week 8 of the development of the baby, because the left side of the jugular vein regresses, and then it is replaced by brachiocephalic vein here, joining the 2 jugular veins. And then you have the coronary sinus, which will drain only the blood coming back from the coronary circulation. Okay? What happens when you have persistent of left superior vena cava? You do have the persistence of the left superior vena cava, which does not regress. This will drain into the coronary sinus. So half of the blood coming back from the head of the baby will reach the coronary sinus, and creating a significant dilatation of the vessel. Also because the brachiocephalic vein in this case will not develop. So this is why you have a dilatation of the coronary sinus. Keep in mind that you have 3 vessels which may drain in the coronary sinus in an abnormal way. In 99% of the cases is a persistent left superior vena cava, which I showed you in this diagram. In less than 1% of the case, each is either the ductus venosus or the pulmonary veins. So again, you have a very rare form of abnormal pulmonary veins return, the intracardiac type, in which the 4 pulmonary veins are meeting behind the heart and then enter the coronary sinus rather than entering the posterior wall of the left ventricle. Coming back to the issue of the persistent left superior vena cava, why is the coronary sinus so different in size? Because in this case, which is the most common occurrence, you have a persistent, you see this drawing here showing you how the persistent left superior vena cava will increase the size of the coronary sinus, which courses in the groove behind the heart, in between the atria and ventricles, okay? So in this case here, there is a mild dilatation because you see here on the strivesal view that both the right-sided one and the left-sided superior vena cava are present at the same time. So the coronary sinus has to accommodate half of the brain, of the blood coming back from the brain. In the second image that you see here, you have very unusual condition. This is the trachea, this is the ductal arch and the aortic arch, and this is the persistent left superior vena cava, which is existing on the left side, and is absent on the right side. So in this case, the coronary sinus is larger because the whole of the blood coming back from the fetal brain should pass through the single venous vessel, which is the superior vena cava, left-sided superior vena cava, and that's why the dilatation of the coronary sinus is much more pronounced than in this case. And on very rare occasion, you may have another increase in the amount of blood passing through the coronary sinus, because you see here in this image that in addition to the left superior vena cava, there is also an azygos continuation. So in this case, which was an isomerase, also the azygos continuation was draining not in the brachiocephalic vein because it's not there, but was draining into the coronary sinus. So that's why there was huge dilatation of the coronary sinus. The reason why dilation of the coronary sinus and the persistence of left superior vena cava is associated with ventricular disproportion is explained to you by this cast that I reproduced with stick. And you see here, this is the left atrium, and the white vessel here is the persistent left superior vena cava and coronary sinus. And you see that the coronary sinus embraces the heart from the back. This is the back of the heart. And see how is reduced. The purple one is the left atrium. And so this is the mitral inflow. And you see the discrepancy in size between the inflow on the right side and the inflow on the left side. And this is why by reducing the inflow on the left side from a extrinsic compression due to the dilatation of the coronary sinus, you may have ventricular disproportion in case of persistent left superior vena cava. And keep in mind also that if you look in the book and the pediatric cardiology books, that the presence of a persistent left superior vena cava increases the risk of aortic coarctation. So you have on one side another cause of possible ventricular disproportion, and on the other side, you may have an increase in aortic coarctation. So you may have both at the same time. The third point I would like to mention is the presence of redundant foramen ovale flap, which is something we studied recently and we published over the last year in the White Journal. Here is a normal heart in which there is a normal size of the foramen ovale flap, and we have described 4 degrees of prominency of the foramen ovale flap. The first one is a situation in which you have a redundant flap, which is almost touching the lateral wall of the left ventricle, as you see here, but there is no ventricular disproportion, okay? This is grade 1. Then you have a more pronounced situation in which you still have a redundancy of the foramen ovale flap, but at the same time, there is a increased size of the right heart versus the left heart. So in this case, the redundancy of the foramen ovale was so pronounced to create, as I will show you in a while from the pathogenesis, the prerequisite for a ventricular disproportion. And the most severe one is a situation, as you see here, in which the flap is so redundant that sometimes gets stuck into the foramen ovale itself. And so in this case, you have temporary obstruction, complete obstruction of the foramen ovale. And this is why you get a ventricular disproportion. And finally, I know that this is a bit jerky, this video, but you see here at the level of the mitral valve, this white structure here is not the mitral valve itself, because the lateral ones are the cusps, but this structure here is just the prolapse of the huge foramen ovale flap, which gets into the mitral inflow during the diastolic filling. So this is quite crucial and creates an obstruction of the mitral inflow. Why you have ventricular disproportion in this case? Because you have two different mechanisms. The first one is the dynamic obstruction of the mitral inflow, because the ballooning of the flap, which is, you should imagine it as a three-dimensional issue, will reduce the actual inflow across the mitral valve. And the second is that since you should know that there is a preferential streaming of highly oxygenated blood from the ductus venosus through the foramen ovale, thanks to the presence of the Eustachian valve and to the left atrium, so that most of the blood coming through the ductus venosus is streamed directly into the left atrium. This mechanism is no longer in place due to the perturbance created by the redundancy of the foramen ovale flap. These two events leads to, in parallel, an increase in the blood flow across the right heart, and then a significant reduction in the blood flow across the left ventricle, aorta, ascending aorta, and aortic isthmus due to the two events here. And this is why this is a vicious circle which repeats, and this leads to ventricular disproportion, which sometimes may be extremely severe, and also arch disproportion, which extends and involves the aortic arches, because the amount of blood passing through the isthmus is reduced. And so in this case, what you have is that since the isthmus looks smaller and gets sometimes also reverse blood flows, I'll show you in a while, because of this perturbancy created by the redundancy of the foramen ovale flap. So this is the mechanism. You have a reduction in the mitral inflow. This creates a reduction in the aortic flow, a reduction in the amount of blood passing through the aortic arch, and in turn, you have an increased flow on the right side of the heart, and this leads to ventricular disproportion, and this is a vicious circle which repeats with time. And you see here, this is one such case in which there was significant ventricular disproportion, and there was an evidence of a very redundant foramen ovale flap. And this is the corresponding color image of the inflows. And you see how small and how reduced is the inflow on the mitral valve, across the mitral valve, due to the obstruction created by the protrusion of the foramen ovale flap. And in this case, which was one of the severest one, you may also have a situation in which there is a complete mimic of the aortic coarctation, because you look at the traversal view, you have both small sides of the aortic isthmus and turbulent flow, where is reverse blood flow across the aortic arch. And this was not at all an aortic coarctation by the time of birth. But in this case, you know that if you look at the foramen ovale flap, which is so redundant, you should consider that in most of the cases, this baby will not have an aortic coarctation, but still these deliveries should be centralized in referral centers so that the fetus is assessed for aortic coarctation after birth. And this is the same image taken with a longitudinal view. And the final possible cause of ventricular disproportion is aortic coarctation. You may have two types of aortic coarctation. You may have a shelf in which there is just a narrow stricture at the level of the isthmus, which is here, or you have tubular hypoplasia, which is a a diffuse narrowing of the whole of the aortic arch. This is the tiny aortic arch of a fetus 20 weeks gestational age. And this is very typically associated with hypoplastic left heart syndrome, but it can also occur as an isolated finding in severe aortic coarctation. And also you see on this image that one other feature typical of severe coarctation is the fact that the aortic arch is higher in the mediastinum than in the ductal arch, which is called a steppering of the aortic arch because it's hooked up higher than the ductal position. This is very typical if you have tubular hypoplasia, or you may have the two associated. Now, some of you may know that ventricular disproportion is indeed an indirect sign of aortic coarctation. That's a normal four-chamber view that you see here. That's a evident ventricular disproportion, which is typical of the cases of aortic coarctation that you may detect in the second trimester. So in this case are the ones in which the diagnosis is straightforward and clear-cut. And the most challenging and subtle to detect are the aortic coarctation in which there is a moderate ventricular disproportion, such as this one, which is occurring and being manifest only in the third trimester of pregnancy. And these are the ones that are lost and are false negatives for aortic coarctation. Considering that aortic coarctation is a ductal dependent lesion that needs to be operated very early in life, in the second or third day of life, then you may easily consider how critical is the diagnosis of these cases. Sometimes you have an indirect sign of aortic coarctation which is not evident on the four-chamber view. You see this four-chamber view which does not have virtually any degree of ventricular disproportion, which you can pass it for normal. And you can also pass for normal both the left outflow tract and the right outflow tract, which looks normal if taken singularly. But then when you compare the two vessels on the three-vessel view, you see here that's the pulmonary artery, and this is the aorta, and this is the same size as the superior vena cava. Then you realize that in this case, the aortic isthmus were really low, and this is one case of confirmed aortic coarctation. The gold standard for the diagnosis is, of course, also the color Doppler, which should be used on the three-vessel view. This is a normal appearance of the three-vessel view with the two arches which have the same sides and laminar blood flow going towards the isthmus portion and the entrance of the ductus into the isthmus portion of the aorta. This is consistent with evident aortic coarctation. You see how small is the isthmus and the whole of the transverse arch in comparison with the ductal arch that you see here. In this case, you have extremely severe aortic coarctation because you have even difficulties at picking up the tiny aortic arch. So this was a prevalent ductus, and this was the very, very tiny aortic arch. And then you have the very severe ones consistent with the diagnosis of tubular hypoplasia, in which you have a very tiny arch, which you will be able to see only because you see flow passing through it. So you have this reverse blood flow across the isthmic portion and a very, very tiny aortic arch. And this is the typical sign also for, as I was telling you before, for hypoplastic left heart syndrome. Also in the first trimester, you can close this diagnosis. If you have a univentricular heart and go to the three-vessel view and see this sign, you can be sure that there is hypoplastic left heart already in the first trimester, 12, 13 gestational weeks. And this is consistent with this type of aspect here. Does stick helps in getting some diagnosis? Yes, it's a subjective thing, but indeed it can be used. This is a normal fetus, and you see that in normal conditions, you have the ductus, which is this one, which inserts onto the continuity represented by the whole of the aortic arch. You have the three vessels of the neck, and there is no shelf here. So this is a normal condition. In severe case, such as this one, you see the tapering, which means that the aortic arch is higher in the position on the mediastinum in comparison with the ductal arch, okay? There is a tiny, tiny aortic arch. And you see also another finding that I will be describing over the next few slides, and that is that there is a persistence of blood flow also during diastole. You see here the color never disappears from the isthmic portion of the aorta in quartation, in severe quartation, whereas in the ductus, the flow is pulsatile, as it should be. And this is called diastolic tail or turbulent flow, which is another typical sign of aortic quartation. But you may have, you may use stick and color Doppler also to demonstrate actually an aortic arch which has only the shelf, which is here. All of these were confirmed cases of aortic quartation. And in this case, you have only the shelf, but the remaining part of the arch was perfectly normal. So it, yes, can help you to finalize the diagnosis, but you should rely mainly on two-dimensional assessment of the three-vessel view for the definition. And of course, I should mention, as I mentioned before, for the pulmonary veins, also for the aortic arch, the new technologies on using this kind of glossy and very sensitive Powell Doppler on 2D transducer, high frequency transducer, can very well replace the 3D of the stick in the definition of the aortic arch as well. This is the sign that I mentioned before, the persistence of blood flow across the diastolic part of the cardiac cycle. This was a quartation detected at 21 gestational weeks. And you see here that there was a significant flow across the diastolic phase of the cardiac cycle. And this is called also diastolic runoff. Whereas the normal appearance should be like that. You should see only forward flow during the diastole, and there should be silence after that, during the whole of the diastole. If you see such a flow or even reverse flow during the diastole, of course, during fetal apnea, not during breathing, which is normal, but during fetal apnea, then it's consistent with turbulent flow, which is one of the highly sensitive signs which have been described for the diagnosis of aortic quartation. Another sign is a biometric sign. You should compare the sides of the ductus and the isthmus, but also you may use like a linear Gardner group described the zeta score of the isthmus of the aorta, which was normalized, is usually normalized on the femur length to provide an idea of the size of the baby. And you get the zeta scores of the aortic isthmus, and this is quite sensitive. And usually the cutoff is set as minus 3.7. If the fetus has minus 3.7, the percentage of fetuses with severe quartation, which needs to undergo surgery, is quite high. But you see there is an overlapping among all the categories. So this is a good tool, but it's not, of course, a magical stick. This is a nice paper 7 years ago in Circulation, in which they, in a decent population, sample-wise, they compared all the different signs to see which one was more sensitive for the diagnosis of aortic quartation. And you see that if the endpoint was surgery, the flow disturbance, which is just what I mentioned to you before, is the one which is the highest sensitivity in comparison with the other findings, as you see here. So for the aortic quartation, how do we manage the issue of aortic quartation, considering all the problems that we have in this type of diagnosis? And there is a long flow of literature over the last 20 years trying to address this problem. And I will just mention two relatively old papers, but I think that clinic-wise, they provide a very good estimate of what is the current situation and what is the correct management for these fetuses. The first one is by, I think, one of the pioneers in fetal echocardiography, which is Lindsay Allen and Garlin Charland. I was at Guy's when they were working there, and that's where I learned my fetal echo skills. And their conclusion, it was 94, but sadly, the same conclusion do apply and stands real and unchanged also now. The most severe forms of aortic coarctation, you have no doubts about them. You can diagnose very easily in the second trimester. The milder forms are consistent with the normal early fetal echo. At that time, early meant 20 weeks gestation. Nowadays, early is 12 weeks gestation. However, in late pregnancy, and this is also true now, it may be impossible to exclude categorically the presence of aortic coarctation if a fetus is referred for fetal echo and does have minor degree of ventricular disproportion. In their experience, as you see, at that time they had 80 cases. There was 2 out of 3 cases were confirmed, and there was a 30% rate of false positive. That's a huge number. And the numbers are more or less the same also today. And the second paper was published in 2007 by a Korean group on prenatal diagnosis. And they called the right ventricular disproportion, called it right dominant heart, but it was the same time. And they plotted the size of the disproportion, the degree of the disproportion versus gestational age. And you see that all the true positives, which are the red blots, are here, and the false positive are the blue ones. And if you draw a line, you can easily see that most of the true ones are detected until the early 3rd trimester, whereas the false positive are virtually all in the 3rd trimester of pregnancy. So their conclusion, and this is also what we use for counseling for a late referral, that a case referring the 3rd trimester for motor ventricular disproportion as 86, we use 90% figure, 90% chance to be normal. The issue is that if you have a 10% chance of having coarctation, which might need an operation over the first 1 or 2 days of life, then you have you are bound to centralize to referral hospital these fetuses, 10 fetuses, just to save 1. But that's the procedure. You have to, for a referral in 3rd trimester, you do have to centralize these fetuses. So the conclusion for the diagnosis of aortic coarctation is that the diagnosis of severe cases is relatively simple. The diagnosis of less severe or late onset cases remains challenging and very subtle still today. Cases referred after 28 gestational weeks have only a 10 to 15% chance of being related to coarctation, but still they have to be referred for delivery in tertiary hospitals. And for the glass body, but with the new transducer, probably this is not needed anymore, may or might, I would say, contribute to increased detection rate for aortic coarctation, even though there is no randomized trial on that, and it's just a subjective impression. Coming to the conclusion of the talk on the ventricular disproportion, the 4 endpoints of a fetal echo in case of a fetus referred for moderate ventricular disproportion are exclude or diagnose the total form of abnormal pulmonary venous return by checking the pulmonary veins. The total form, because if you have a partial abnormal pulmonary venous return, in most of the cases, they do not only do not represent a neonatal emergency, but in most of the cases, they do not need to be operated at all because they are consistent with the perfectly normal life. You have to see whether there is any persistent ablative superior vena cava, if there is dilatation of the coronary sinus. Consider that persistence of ablative superior vena cava is a finding which can be associated also with some genetic conditions. So you should reassess genetic-wise the baby, the fetus, if and discuss about CGHRA if you find persistent left superior vena cava. The third possible diagnosis and cause of ventricular disproportion and the prevalent one and what the most severe one probably is the presence of the aortic quartation. So with the direct diagnostic evidence with all the limitation that and the caveats which I mentioned before, is made on trivassal view with color Doppler as well. And the fourth cause, which is responsible for a large number of false positive meaning referral for ventricular disproportion, which is indeed there, but in fetuses which did not have eventually an aortic quartation, is the presence of a redundant foramen ovale flap. So this is a relatively common occurrence in the third trimester of pregnancy. So if you have a fetus with a moderate ventricular disproportion, also severe ventricular disproportion, before increasing the probability of having quartation and telling so in your counseling, have a look at the foramen ovale flap, because if there is a significant redundant foramen ovale flap, that may only be a false positive for aortic quartation. And consider eventually, but this is really a point that you should have in your mind quite clear, that there is a physiologic increase of the ventricular disproportion in the third trimester. So eventually, most of the cases with moderate ventricular disproportion referred to for expert opinion in the third trimester will have a perfectly normal heart. And I thank you for your attention.